The way I defined these types of changes to patients is I first start off with the understanding that our bodies are built of trillions of cells, and each one of these cells has, with some exception, has DNA. We inherit half from our mom and half from our dad. So germline is really, I think, put into a simpler form, is just heritable mutations, things that could be passed along from generation to generation.
One of the first things I would tell someone is to make sure that you discuss the difference of doing genetic testing in the person for a germline mutation, something they inherited, versus looking for somatic mutations in the tumor themselves, because patients still continue to get that confused as you're talking between the two different types of testing.
Based upon the history of our business and our industry, so to speak, we now know that there are certain times you really want to have both testing done of normal tissue as well as cancer tissue. Other times it's probably not going to be as important. But to really explain this to our patients, we're going to need, as healthcare providers, the knowledge to say, hey, what is this test really actually measuring, and how do we actually interpret that? And then what are also some of the kind of provisos required for normal DNA testing, what we call germline testing, because that requires a consent ahead of time where tumor tissue testing does not. Not all the tests are the same, and so every person really needs to understand when they're ordering these tests, what is it about this test? Does it require a normal sample? Does it not require a normal sample? What is it about the results? Did it take into account these normal samples? Did it take into account that it wasn't included in the actual testing?
Or, quite frankly, a lot of these panels have genes that we still don't have clinical information or guidelines on what to do, and we need to talk to patients about some of the ambiguities of doing big panel testing so that they understand that they might get an answer of, this is very interesting, we'll continue to follow, but I don't have specific guidelines. One of the biggest misconceptions I get from patients still is that they assume that every breast cancer is related to a gene that we can find on a multi-gene panel, when in fact it still remains a very minority of patients that we find this. And I think patients can get really distressed. They were hoping for some reason, something that they could point to that they got why they're dealing with this cancer, and sometimes that can be really unsatisfying for patients. So I think making sure that you address that, discuss it as one of the potential outcomes, that you're going to do all this testing and that very likely we might not find anything that gives us a clue of why they're dealing with that cancer.
You may want to consider recommending a genetic counseling to them so they can consider various screening for malignancies. And if you find an earlier stage disease with a germline variant, you may want to screen that patient for other malignancies. These oncogenes are less and less prevalent, the ones we can target, so it's very hard to screen for them without looking at a panel. If you just do a single test, you're probably going to exhaust much of your tissue just looking for a single biomarker, and that's why this technique is so powerful.
What I like to tell patients is the first thing we need to do is figure out whether or not there's something we call actionable. And that has many different definitions, but for me, and I think most patients, is there a trial where there's an experimental drug that's targeting something in the molecular underpinnings of this patient's cancer? Or is there already an FDA-approved drug for a different cancer type, but we happen to have the same mutation in this particular cancer, and could we get off-label use, as we call it?
There's quite a plethora of trial options right now. The matter is really matching your patient to a trial based on the results you have from your sequencing. Sometimes you find a rare mutation that your institution or your center may not have a trial for, but there are others in the area. So it's critical, I think, to try to find these.
There are patients who have something that match for a trial for a targeted therapy, but the travel distance is not realistic. So there's a pragmatic issue right now where patients can't travel, they can't live at the institution that's 2 hours away or even 2 days away to participate in that trial. The number one thing I would advocate for is that these are very, very difficult, complex decisions oftentimes. And so I would advocate that first we need to convene expertise in molecular tumor boards. This is something we've done at Hopkins and now really is kind of taken shape across the globe. But to have someone with trained eyes, expertise in this field, to really go over a report and demonstrate to the patient and the rest of the healthcare team what this report can and cannot say in terms of what drugs or what steps to be taking next.